want to welcome you to the community engagement meeting and thank you for all your attendance and hopefully participation in the meeting. My name is Tiffany Fritz. I am the Division of Health and Community Services Division Director, and I've also been the Project Director for the Rural Communities Opioid Response Program, the planning grant that we received from HRSA. Staff that's been working on this has been Mee-Kai Clark. And she's been working as the outreach specialist, and Brian Kirk, who's in the back, he is our tribal planner. So between us three, we have kind of been working together and putting a consortium together and just been working on a planning grant for a potential treatment center here. So before we really start and dive in, we really just wanted to welcome everybody. We have a little bit of food, so we're going to say a prayer over the food, and then during that time, we'll do an introduction of kind of what the program was about, HRSA, and then Brian will be going over our PowerPoint presentation of basically what we've been planning for a year with our treatment center. And towards the end, there'll be a lot of Q&As. So we're open for participation, any type of opinions, responses, comments, and so we have things written on the walls here. We have markers, and so we really just want it to be an informal meeting, but really engaging and really just involved. So thank you all for coming. But we have asked Mike Ortiz to say the prayer over the food.
Father, we thank you for this gathering of people this evening and sharing of the information that's we need within our own community. Thank you for the provision of food for sustenance this evening. We pray for these safe travels for those that are going home this evening. And with each and every one that's within this room, continue to provide direction for each and every one of us. In your name we pray. Amen.
For those of you that don't know me, my name is Mee-Kai Clark. I was selected to be the outreach admin assistant for this grant back in November. So for the past 10 months, I've been working along with tribal planning and with the Division of Health and Community Services to implement and try to complete the objectives of this program. So I'm just going to give an overview of what this program is, because I know some people have heard of us, some people haven't, but we are funded through HRSA, which is the Health Resources and Service Administration, and our mission is to improve health and achieve health equity through access to quality services, a skilled health workforce, and innovative programs. HRSA supports over 90 programs that provide health care to people who are geographically isolated, economically or medically vulnerable through grants and cooperative agreements to more than 3,000 awardees, including community and faith-based organizations, colleges and universities, hospitals, state, local, and tribal governments, and private entities. So the Federal Office of Rural Health and Policy, this is just an overview of this program, which actually manages our court for the Rural Communities Opioid Response Planning Program. The mission of their program is to provide policy support to the Office of Secretary and provide grant funding at the state and local levels to improve access, quality, and financing for rural health care. The office is divided into 4 divisions, all supported by the Office of the Associate Administrator. The divisions are Policy and Research Division, Community-Based Division, Hospital State Division, and the Office for the Advancement of Telehealth. Our program, our court, is managed under the Office of Associate Administrator. Okay. So this is the overview of our grant. So the Rural Communities Opioid Response Program Planning purpose is to reduce morbidity and mortality associated with opioid overdoses in high-risk rural communities by strengthening the organizational and infrastructural capacity of multi-sector consortiums to address prevention, treatment, and/or recovery at the community, county, state, and/or regional levels. So this is our program here, the purpose of it. And then this is the actual Pawnee Nation, what we're doing and what we've been doing for the past year. So we were awarded in September of 2018 for this one-year planning grant working under the Department of Health and Community Services here at Pawnee Nation and the Office of Tribal Planning. Our primary focus for this grant was to develop a comprehensive treatment facility plan for our region. Our target population included 5 counties, which was Pawnee, Payne, Osage, Noble, and Cade. Our activities included a community survey, focus groups. We had 2 focus groups with community members from all of these counties. We had monthly meetings with our hired consultant for Lake Behavioral Health Management, the Office of Tribal Planning, the DHCS coordinator, outreach administrator, and a developed consortium team, which consisted of the Pawnee Nation Substance Abuse Program and Tribal Opioid Response Program, CREOCS. We had representatives from the Pawnee Health and Wellness Clinic. We had a representative from Hillcrest Hospital and an individual consultant. His name is George Sally. So we began these meetings with the consortium team in February, I believe it was February. And we've been working with them every month, putting together what the needs are. Brian will go into more detail about what we found out in our community survey regarding needs, barriers, if we wanted a treatment facility here. Our focus groups kind of focused, it was compiled of people from behavioral health field, but also people from the community, people who have loved ones that are seeking, recovery from opioid use disorder or substance abuse disorder, people in recovery, and just people in the community who have been impacted. So we got some really good feedback from those 2 focus groups that we had. And then just working with the consortium team, not because we know in rural communities we're impacted, not kind of the same in each area. So a lot of what's happening and going on around the opioid use disorder is the same in a lot of the communities surrounding us. So I just wanted to thank the Pawnee Nation because they were very open to meeting with me and talking with me, their substance abuse program and their behavioral health program. And I wanted to thank the Otoe Missouri tribe also. They were very open in sharing our community survey with their team. They allowed us to set up at one of their events to collect surveys too in person. And then I also wanted to thank Jeremy Fields. He's the one who designed our logo that you'll see. And so if you sign the sign-in sheet, we will have some promo items or stuff with that on there, but then we'll get those to you when they come in. But I just wanted to give an overview, and then Brian will get into kind of the meat and everything of where we're at.
I'm a tribal planner here at Pawnee Nation, so kind of like she said, last year or so, we've been working with a lot of consultants, a lot of stakeholders, and a lot of individuals throughout the community to kind of see what we can do on better serving opioid crisis as well as mental health issues that go on in our community and our surrounding communities. So this is the lovely logo that Mee-Kai put together, but you can see it throughout. So basically, on the first stage of what we kind of did was we wanted to look and get an understanding of our demographics, So we wanted to look at on 3 different levels, primary, secondary, and tertiary levels, and how we were able to justify that was look at distance of our service area. So we were looking at a 15-minute, 30-minute, and a 45-minute radius from Pawnee Nation. This would help us determine the service of need, demographics of individuals that we will be dealing with, and just kind of give us an understanding what it would take to operate this type of facility. So that's kind of like how we broke down the demographic. But we also wanted to see what was out there already, see what we could do in developing additional partnerships, kind of piggyback on other services, or seeing if whatever gaps or limited services that wasn't being pursued could be an opportunity for us to offer here. So again, this is based off of like a 4 to 5 minute radius. So we were looking at different cities. Now there might be a few that are missing, but overall, this is kind of what we wanted to look at. We wanted to see if there's a critical access hospital, what individuals are offering that. Is there any mental health facilities or any other additional substance abuse programs that are going on in our surrounding areas? So this is just the basics of what's going on in our region. So this kind of, so based off of that, we were able to put it on a map kind of perspective of it. So in the center, you'll see Pawnee, so we'll have an outpatient or inpatient type of facility. And then all the red ones are outpatient and the blue ones are inpatient. Now, based off of this analysis, some of these clinics could still be open. We did run across that some were closed for remodeling and such, and we haven't heard about their status of reopening. But we just wanted to give us an idea and visual of where people can get access to care, or where we're taking individuals when they are in need. So again, this is just another visual of the radius of what we're looking at. We're kind of just seeing what cities and what communities was in that 45-minute radius. And that was able to start looking at the population-wise. Now, we looked at projections to 2023 because this will take time to build this type of facility. So within that, in mind, we wanted to look at which populations would grow, which populations would decline. But at the same time, we wanted to see what the target audience would be age-wise, because based off of that, we determine what kind of services we wanted to provide. If it's from adolescents or more from pediatrics, elders, or is it more middle-aged adults. So, you'll see the red is basically the 15 minutes. So on the first column, you see a 0 to 15 minute. So based off of that population, we see a total of 4,100 individuals ranging from, can't be 0, but usually 1 to 65 plus, and then so forth from secondary, which is 30 minutes, which is 22,000, and so forth. So based off the total of those circles, we see that the total population based off 2023 will be a total of 138,000, give and take. So this kind of led us to understanding which areas were we looking at. She kind of highlighted, but another map would tell us this is kind of the 5 service counties that we're looking at. Again, this is not limiting us to only these 5 counties, but it just gives us a starting point to start looking at those 5 counties. And as we grow, possibly we can expand our services on a state or national level, depending on what direction you go. So the first one was just kind of that 45-minute radius. So we also wanted to look at the 5 counties on a perspective of a 45-minute radius. So within that 5 county, we see a total population of about 208,000 individuals. The biggest age group that's in that is basically the age 20 to 64. We see about 117,000 out of that 200. So that kind of gave us an idea of which kind of age to target, but not limit ourselves to. But we also saw that even in the 45-minute radius that we had about 80,000, which was the biggest of the 3 to determine which services we wanted to provide and see which target audience that we wanted to serve. Okay, so then we looked and saw, okay, our total population is about 208,000. Okay, so on the operational side of this, we wanted to see, okay, what would it look like if we had an 80% fill of beds and about 35% individuals using our outpatient services. So we wanted to have a projection of what needs are for beds and what needs are for the outpatient side of it. So this was just some other numbers that would give us justification on which area to kind of target. So when we were looking at these, we were saying, well, if we wanted to concentrate on children between the ages of 0 and 19, we would only need technically 3.3 beds in this facility, or we'd be looking at about 10.8 individuals utilizing our outpatient facility. So then we looked at the middle age, 20 to 20 or 20 to 64, that we're seeing, oh, well, that number drastically jumps to about 31 beds, and we will have about roughly 25 individuals that would be seeking outpatient services. Then, if we wanted to, then it leads to our elders, which was 5.2, to outpatients on 8.3. But if we wanted to address everybody and everything, we wanted to see what facility that would be. So we would technically need around 40 beds, or have a facility large enough to serve about 44 individuals using outpatient services. So that was just on a population level. So basically off the 5 counties. So then we wanted to see, well, what that number would be more on a 45-minute radius. And we see that it does drop a little bit, but drastically the larger number is the middle row, which is the ages of 20 to 64. So we utilized this information to say, okay, we said as a team, all our stakeholders just talked about, okay, what is the biggest need? Because we had individuals that concentrate on adolescents, we had individuals that said on this, that concentrated on geriatrics. Then we just had individuals that just served anyone that walked in the door. So we were just kind of seeing what was basically would best help our community. Even on the outside of it, when we did our focus group, we had individuals that were recovering from addiction, that were still going through some substance abuse issues, as well as, and they all range from different ages, but we got a good information of what they wanted to see, if they were comfortable with having a treatment facility. We also had individuals that were just community members and see how they felt about having a treatment facility here, because there could be some minimal risk that could be involved, and we just wanted to see if they had any concerns or any issues about having this type of facility here. So we were able to conduct the survey with those individuals there, and we hosted about, 60-day online survey. It went for about 2 months, and like Mee-Kai said, we were able to partner outside our consortium and hand out these, the link we did on SurveyMonkey, so we got a grasp of individuals that just was able to add their concerns or add their input. But all that valid information was helping us deciding what we wanted to provide in this treatment facility and just see what services we could offer. So basically through all the demographics and through all the analysis, when we sat as a team, we started discussing, we wanted to see the potential of this treatment facility, what was the services that we wanted to look at. So based off those numbers that we previously saw, we saw the biggest, largest numbers between the ages of 20 and 64. So on the inpatient side of it, it would be adult inpatient services for behavioral health, which is substance abuse and mental health, so it would be a co-occurring facility. But we didn't want to limit that to one, either male or female, so it will be both male and female facility, and I'll kind of show you how that would work. And then what kind of services that we want to address on the outpatient side of it. So on the outpatients, we're not going to limit to only adults. We're going to be addressing adolescents, children, adults, as well as seniors that are looking for any type of substance abuse treatment, they need one-on-one counseling, or whatever, or if it's MAC, if they're looking for medication-assisted treatment. But it will be, the good thing about this is what we're going to try to do is make it more of a client base. So based off of that assessment from our psychiatrists or our behavioral health therapists, they can determine what's the best source of them either finding treatment, recovering, or just maintaining their sobriety, and basically finding a new purpose in society. And based off of that, they can determine what program they need to go to, what is the best roadmap for those individuals. And that would just basically go to, if they need inpatient, we will have access to that. We will have outpatient, which will have a mixture of psychiatrists, nurses, doctors, therapists, and depending on what we do in contracting out, there's opportunities for telehealth. There's a lot of advancements with telehealth now, because you can do a lot of things from home, if that's an option. And then we looked at a financial model. I'm not going to get too deep in that, it's a little bit complex, but we were able to see on the financial model if it's feasible, what would it take to operate this facility, what options do we need to do to be either a tribally owned facility, would it be interest doing a state treatment facility, contracting out and having a third party manage this facility. So there's a lot of other business models that we're still currently looking at to figure out what is our best option to sustain this type of facility. So, and then again, projecting based off the size of this facility and the people that we can serve, this can employ between 40 to 70 individuals, which is a meaningful economic impact. So, then we decide where we wanted to have this facility. We do have a lot of land around here, so what would be the best? Do we want something here to be on the tribal campus, or do we want something to be out there in the community? So throughout the talks, what we thought of doing was basically putting it next door to this building and have it right across the street from IHS. So basically this would be the projected treatment facility. It would have 3 entry points depending on service of care. Main entry will have clients come and get access to in-treatment. It would be employees that would be going in basically on this side of the building. You'll have your ambulance and emergency services have entry on the east end, and then you have your outpatient services on your outpatient. And the way we designed this was we kind of liked the separation where it allowed people to have that comfort of just going and getting access to care. Kind of separated the two, then everybody just sitting in one large lobby and being told where to go. So this is an overall visual of it. It's an old Google Maps. I know some of these buildings, like this building ain't on this map, but you have an idea of like how it connects with the IHS clinic and how the parking lot here would connect to this to allow people coming in and out from different directions. So it just gives you kind of an overview, oversight from satellite looking down where we're picturing this facility. So then we wanted to look at, okay, well, we had that building, so what would be the floor plan? What, how many beds that if we wanted to know how many would be in there, which based off the numbers, we're looking at between 26 to 30 beds inpatient. So we wanted to look at it and separate the two and see what it would look like on the floor plan. Well, at the same time, we wanted to see what it would look like on the outpatient side of it, administrative side, and so forth. So this is basically kind of basic floor plan that allows us to kind of say, we've got people that are a threat to themselves or other individuals. They got exam rooms and we can have one-on-one sessions to be evaluated, determine if they need to go to inpatient or be sent somewhere else. We also got certain regulations will allow you to have a kitchen of some sort, so individuals that are staying at the inpatients have access to the nutrition component of this facility. At the same time, at the front entry where they have a lobby and they can have access to one-on-one evaluations before they move into the next component of being admitted into the inpatient. We have some other little rooms for detox and other things that take time for them to actually get admitted into the inpatient. So we'll have those type of facilities to address those needs. So going down to the treatment, you kind of have your nursing stations, and then you have 2 separate wings. Now, the good thing about this, it has the flexibility that, if we have more women come in versus men, this is not set in any type of way, but it allows us to, whoever we're addressing, we can separate the two because they got doors and things like that that prevent them from crossing over at any point in time. So, but on the larger wing, we will have some type of, we're not going to specialize it, but we will have a couple of rooms be able to address elders, so have special railing and so forth. So just to have accommodations for them in case they're looking for any type of inpatient facility. We will have that in place, but again, we won't specialize, but we would be able to address and serve those individuals. So once they get done with that, then we have in green is our administrative. So this is going to be a lot of doctor offices or administrative personnel, if that's SAT program or third-party billing individuals. but we just have a lot of rooms for administrative on the behavioral health side of things. So then we look at the outpatient. So during the outpatient, they'll have as well a lobby there, when then you'll have 3 different group rooms, not really set in stone. One could be opioid group, or one could be alcohol, or whatever we are addressing. We have 3 different rooms that can address any other illness that might be happening. But at the same time, we have individual rooms. So if people are more comfortable having one-on-one sessions, or just want to have that sit down, they have the separation and set up in place that allows them to do that as well. But that's basically the floor plan. Now there's maintenance rooms and things like that, but basically that's the overview of it. So we're looking about roughly about a 29,000 square foot facility. And what's unique about this is it gives us the ability to expand. So how those wings are developed, and how we have some open spaces and administrative, as well as on the east end, we have opportunity to, as we grow, we can expand that. So if we see that there's a bigger need of more beds and things like that, we have the capability to add on to this facility. So we're not just limiting ourselves and stuck to this. So that was an overview. So this is just a rough drawing. That's really, we're not sticking these colors or whatever, but it gives you kind of visual as you pull it into the parking lot of what this facility could look like. So this is the front entrance coming into the in-treatment side of things. So that's what it would look like. We would, have a canopy with our seal, a couple windows, and so forth, and some nice landscaping, a lot of Priuses. But then we wanted to see, okay, what would the outpatient side of it? See, it kind of secluded, it kind of separates it. It's more on the west end of it, but you have that capability of looking at, it is separate. People can park over there and go directly into the outpatient wing if needed. And then you have, and then the other end, the shorter wing of the inpatient, and there's probably going to be an emergency exit in case fires. Same way with the east end. This is a larger wing, so they have some rooms will have windows so they can look at. They're not just stuck in a room with no windows, but they're able to just look at and look at nature. So we wanted to see what this would look like from the again, the west end with the outpatient side of it. So this is more the administrative parking lot. So you can see there's access to the door right there. So your administrative is never really walking into the lobby. They just go straight to the office here. So it's just another technique to kind of keep them separated. Just kind of increase that privacy level with our clients and our administrative staff. So they'll just go straight into there. So the bigger picture and the number one question is like, okay, that's fine and dandy, but how much is it going to cost to run this type of facility? Roughly looking at around $15 million to build this facility. This is just not based on inflation. This number could go up over time, but this gives us an idea and a range to start looking at and seeing, okay, what is construction cost and what is all the internal parts that would take to build this, So when we were working with our consultants, we hired an individual that builds nothing but treatment facilities all over the state of America. So all they do is, that's what they specialize in. So they build treatment facilities in Texas, Tennessee, Florida, and so forth. But they were able to look at, do a compare analysis of what, construction costs would cost in the state of Oklahoma, and what's kind of the range of basically square footage wise of what it would take to build any type of treatment facility or a hospital. So that's how we were able to use that information and have a driving factor into it. Now, a lot of the funds are fees and furniture and some other things that we can explore and see if there's ways to minimize this, the cost. But basically, shell-wise, we're looking about $10 million to build, and then some additional costs like security cameras and other things that are included to have in place and must have in place on the infrastructure and hardware side of it. Is a hefty cost, but it's well needed in these type of facilities, even if you're trying to get any type of certifications or license. So those are kind of a must need, and then you have a contingency, so that gives and take it. But overall, excluding inflation, we're looking about $15.5 million to build this. So that could be alarming to some, but I'm a guy that looks at the glass half full. We can do it, but it will take time. But overall, we wanted to see, okay, well, if it's going to cost $15 million to build, what are we looking at on the staffing side of it? I mean, jobs it's going to create, who's going to office, and so forth. So we were kind of looking on 1 year versus, let's say 5 years down the road. But, so, the first year, this is what it would basically take to staff, so it's a little bit lower numbers, but a lot of these, as more clients come in, you're going to need more people to do third-party billing and so forth. So those numbers will go up. A lot of these, this is just basically starting from scratch if we want to hire everybody, but some of these can do double duties, like you can have a CEO and a DON at the same time. But if we just wanted to have it basically hire everybody, this is basically what it would take to operate the facility in the first year, and then what it would take after our name gets out and more clients are coming in. How much do we have to grow our staff to still operate this type of facility? So that's that. So the biggest question is like, okay, where does this lead us? Where does this put us? What do we do next? Because it's going to take a lot to come up with $15 million. So how do you come up with $15 million? So there's a lot of avenues that we can explore. Currently, right now, we're still working on a marketing plan. So this will be able to allow us to go to private and public funding agencies and just promote what we're trying to do here and get that interest where they'll be willing to invest. There's also grant opportunities, there's loans that we can go into, and then we want to see what we can start looking at on the federal side, what we can start looking at on the state side of it, because on both of those, I mean, they're releasing a lot of funding right now on the state side as well as the federal side, being addressed to opioid issues. So there's other things that we can start doing now. I know we can start collecting third-party billing now to start bringing in some revenue that we can allocate for construction options. So in the meantime, we can set up some third-party billing, bring in some funds, as well as looking at services and other things that we can maybe strengthen. If that's developing new partnerships, or if that's some things that we're not addressing, what could we address and offer those services on a nation side, on a local and state and federal side. In the meantime, depending on which route we go, there's certain requirements on license requirements. If we go the IHS route or the tribal route, the biggest concern on that is being able to build that third-party billing, because especially when you start dipping into private insurances, Medicaid, Medicare, and things like that, they require certain things. So if that's the case, and we were looking at that as one of our drivers for income, it might be the best interest of doing a state-certified treatment facility, which is not a state-certified treatment facility in our region. I believe there's only actually 2 in the state of Oklahoma. And we can possibly be the third one if that's the avenue that we want to explore and look at. But on the sustainability aspect of it, that could be something that makes us go that route. But again, developing a marketing plan, start looking at other options to just get our name out there and just see what we can do to get people to invest in this. That's the biggest issue, because we all know that it's a huge need. So throughout this year, we were able to kind of see if it was feasible, and if it was feasible, now, which leads us to the next objective is bringing in those type of revenues, those partnerships. There's numerous ways to do it, so we're still just coming up with some creative ways to kind of do it. But basically, that's it. That's what we're looking at. We're still, even though this grant ends, it's still, we continue moving forward in networking and partnering and getting the resources that help us create this treatment facility. So that's basically it. Got any questions, suggestions, ideas, or let me know if I'm missing something or didn't address.
If you have it like on a state level facility or whatever, are you still be able to like put your cultural aspects into your programs and things like that?
Yeah, when we started looking and exploring the state versus tribally owned facility, there's requirements that we have to fulfill, but it doesn't limit us from being creative and flexible. So we can still have a preference if we wanted to. We can still add new things if we want to not solely do the Western size type treatment, but add some cultural, spiritual type of treatment options. We have the capability of doing that as well. That doesn't prevent us from offering that. So yes, we can still be able to address all of those things. And that's what's, I think, unique about this, and what's a good selling point is that we've already started looking into that, and I know this Barber's program, they're pursuing some more cultural type of services, but we'll be able to easily put that into this treatment facility. When we start looking at clients, everybody's different, so if we can find the best way for them to kind of find a purpose and get them help, that's what we want to try to accomplish.
On your floor plans, I didn't see anything on there. Well, of course, I couldn't see very well when I pay.
I know, I tried to make it bigger, good.
Like you had an exercise room, or was that something included?
We
in your
thought about it,
plan
but
or something?
as we thought about it, we wanted all the best things for it. We were even thinking about having an outdoor park, because a lot of these treatment facilities do have those, but then you start driving up the cost. So we had to look at ways to kind of be like, okay, do we have a gym here? Yes, we do. Maybe we can and work on a transportation system that allows them to go to the gym for an hour? Do we have an outdoor basketball camp on the campus? Yes, we do. So could they go across the street and use this facility? So we didn't want to duplicate things that we already have because it drives up the cost, and we were already kind of seeing that this was going to be a large project. So we had to take some of those things out. So it was talked about, but we were trying to come up with some ways to save costs.
Okay, my next. You guys are using the word opioid. But is that like, I don't, when I hear opioids, I think pills. Is that, am I?
Well, that's one little component of opioids.
But is that, or is that just another word for drugs?
Well, opioids, it is another word for drugs, but it's a little component of drugs. Because you got, cocaine, you got opioids, you got meth. I mean, they're all a drug, but they're just different little components.
Well, that's what I mean. Opioids, I look at it as like the pill, the pain pills, and we all know that that's a big epidemic and how that's being abused. And now I just cut everybody off their pain medication because of it. So it's like, okay, is it just opioids that's dealing with pill addictions, or is this talking about a facility for the whole, the alcohol, the meth, all the other little hardcore?
It would be for everything. So we're not limiting ourselves to opioid. We know that's the biggest epidemic that's kind of unfolding now. But again, I know based off our community, we see a huge issues with alcohol. We see a lot of issues with meth, and we'll still be able to serve those individuals. And that's why I kind of like this, the model that we're looking at, is because it will be a client-based type of facility. So the service that they get will address their needs. So we'll be really flexible to address whatever their issue that they're dealing with. And that's why we incorporated mental health, because we know they kind of correlate, and we want to make sure that we not address the substance abuse side of it, but we're also addressing the mental capacity of those individuals that will allow them to get the help that they need.
And you said there's 2 others in the state of Oklahoma?
For the research when we were doing, there's only 2 state certified. Now, there's a lot of private owned, there's a lot of other treatment facilities out, but
The Osage.
The what?
It doesn't include Whiteville or the Osage.
Oh, okay.
Yeah.
Yeah, I thought those were travel.
yeah, and they exist. But from our research, and we had the state of Oklahoma be one of our consortium members, and they are the substance abuse program out of Oklahoma City. So, but they were able to kind of give us some information, and that's why I thought it was unique to increase that opportunity if we wanted to go to state certified. I mean, we're looking at a lot of avenues and giving a lot of people access to care on a broader level than just addressing natives, because when we were talking and stuff, like a lot of these individuals kind of hang out with, there are groups of individuals, and what the friends may be not native, so they can't get help, so they get thrown back in that environment that could lead to relapse and stuff like that. So we wanted to keep it flexible, but again, I don't make those decisions, so that can change. But these are the things that we've been talking about the last year or so, what we can do to not just address our people, but everybody across the board if it's feasible.
Well, since this is a few years off, you guys might start looking at your college students, start pushing them in directions and maybe fill some of your positions. Just a suggestion. Because we always, want our tribal members to come back, work for the people, and, just go Because I know a lot of tribes, they invest in their college students. Rather than go to school and get their degrees and, fill the different positions.
Yeah, and that's what we're going to start working on now is developing those partnerships and figuring out ways to just increase our capacity here on a larger scale. So I know that's been talked about numerous times. We're definitely going to pursue that.
Is it comparable in size to the other two state ones?
No, because our region's a little bit different. This is this is a very small facility compared to a lot of other facilities, which was kind of alarming, but that's why we wanted to look at the sustainable aspect of it, because why we designed this, because based off our regions, the numbers are low. We're in rural Oklahoma, so we're not going to be servicing that large of individuals, let's say comparable to Tulsa or something like that. So a lot of these facilities are a lot larger, but I think what could make us unique is if we went maybe on a larger scale of being a state certified, we would be serving people from all over, which will help generate some capital that would give us the availability to expand. And the way that this design was, we can, if those wings right there can keep going out if we wanted to, or we add another hallway on the south end and add additional wings as well. But it just gives us that capability. As we grow, we have the potential to grow this building as well. But it is a small one.
Just a quick question, of the two that are state certified so far, what are the two facilities?
I don't remember the names of them. I just asked how many was in the state when we were talking to the lady that sits on our team. And I believe they were in the bigger cities like Oklahoma City and Tulsa, but nothing in rural Oklahoma. But I can get that for you. We meet in the month, so next week. I didn't know. I just want to know how many it was, to see what we're on a competitive side of things, what we're dealing with. So that's why I just asked them. And again, as additional questions come up later afterwards, feel free to contact me. Probably should have added my contact information on there. But that's it. That's what we're shooting for. That's what we're visioning. That's it. But now let Tiffany kind of finish up strong and let her. Go.
Oh, yeah. Okay. I already forgot what I was supposed to be doing. I was like, we really didn't want to leave on like a sad note of this is what we've been thinking about and this is what we want to do and not be able to have anything. So I really want to make sure that you all know that we do have current services that are available. So people that are on my team for DHCS is Barbara Pawnee. She's the substance abuse program coordinator, also the tribal opioid response coordinator. Lady in the turquoise right there, not looking up. But, and then Mike Ortiz is the counselor over at Substance Abuse Program. They do have support group every Wednesday night at 7 o'clock at their facility. There are other facilities. There's the UCAP office. They have them on Tuesday nights at noon time.
8 o'clock, I think.
So at the UCAC, there's 8 o'clock. On Thursday nights, there's one at Family Worship Center. That is Mike Godwin's. He's at 7 o'clock. So we do have current services. I didn't know if we have prevention services. We do post-recovery services, but we don't do our own treatment. So we do refer out to, and we work with 12 and 12 in Tulsa. So I didn't know if maybe substance abuse program wanted to give a little spiel on maybe what they're actually doing, what current services are available. So in case anybody needs anything, the people who to talk to, and then the kind of the relationship, how that goes when you come through SAP doors and then working with Indian Health Service. Either one.
While Mike's going up there, I may add that we've done a survey, and with the people that participated in our group now, and we are looking at adding another night, and so the best night that we're looking at will be Monday nights. We haven't got it started yet. We're waiting on it. We've been having problems trying to get our books ordered, and that will be an NA meeting, but that doesn't, that's one thing we don't separate. You come in, everything is treated the same. If you have an addiction, whether it's alcohol, meth, opiates, we don't separate them. We come to group, and it's all looked at as an addiction. So this gives the people that can't make it to that meeting another option, and we'll be putting out a flyer or in the newspaper and stuff once that meeting gets up and going.
Okay, with that being said, we are an outpatient facility, okay, which means that when somebody walks to the door, the criterion that we meet is that they're not in immediate medical distress, emotional distress. We do what's called an ASI, or the Addiction Severity Index. That's our assessment tool that we use at this time. We do use the Native American version of it. That helps us to help direct, develop treatment plans for individuals when they come to the door. A lot of times, if a person, say, is, well, depending upon their level of addiction or the severity at that point in time, we may not be able to serve their needs at that point in time. Like Brian alluded to a little while ago, the psychological side of things. Our point is when somebody walks through, is if they're at a certain level of recovery, yes, we can meet with them individually. You have different levels of care, anywhere from standard outpatient to intensive outpatient to inpatient, different types of processes. It's difficult a lot of times when somebody walks to the door, or a parent calls, a family member calls, and they're trying to get assistance for people that are really in need. We have to look at payments being rendered, so a lot of times we have to use or direct somebody to IHS, and if it is determined if the individual needs inpatient care, okay, we'll make that referral to the clinic, let them go ahead. There's a process that's involved. The physical has to be obtained, a TB test, hepatitis panel. Primarily when you're looking at those kind of things, you're looking at the well-being of the caregivers. Not to mention just the immediate medical stability of that person at that point in time. It's a difficult road for a lot of people. We've had to go on a few calls where, this happened some time back, that say a house called the one individual who was severely beaten by a shovel, pretty much left for dead, and we had to go out with the private police to go check on that person. The individual called a couple of days prior, wanting to come in for inpatient, but it was pretty much incoherent, so you really can't determine where they're at and to run into situations that are beyond our immediate ability to help. So we do try to assist in every way possible. We utilize our inpatient treatment monies now with 12 and 12. The turnaround time is much shorter in getting somebody in. The current criterion is we try to use specifically for tribal members because we're trying to figure out exactly how far these dollars will go. It may come to the point, and it probably will, that we'll have to expand out to anybody who needs those services. But here again, that particular facility, they do have guidelines that they have to follow. It's like an individual cannot have a violent crime within the last 5 years, cannot have any outstanding warrants for inpatient services. They can put it through detox, but they will be released immediately afterwards. Okay, so we're looking at short-term solutions a lot of times. And when we come back to the individual coming back for an outpatient approach to things, we have some that may well need to be inpatient, but choose not to. So the alternative is continue to do the best that we can and hope to make a change in that, in the way that they're approaching things. That's where our facility, a lot of times we see us, we're working within the community because that's where the changes have to take place. When you come into the outpatient or inpatient type of facility, that's the end result. Okay, that's still not the root issue a lot of times. Okay, so that's the first cause of concern, the first area that we have to approach, we have to address it. We have to try to take care of that side of things. And then we can begin to work on the additional concerns. There's a lot of factors involved in it. The approach to the inpatient facility, that would be a great asset. It really, truly would. Hopefully we can get that off the ground and make it a go. But for the interim, I mean, let's see alternatives that we have. Like if we try to get someone inpatient to a different tribal facility, say Pahuska, Ada, Clinton. A lot of times it takes up to 6 weeks to get somebody in because we have a limited amount of bed space. And here again, it's who's paying the bill. That's the bottom line. And it's just something that we really have to be concerned about. We have to look at each and every time. Do you have any other questions or concerns about that? If I didn't explain things well enough, nail me down, make me answer you. Okay? So I'll go ahead and open up. Anybody have any questions?
I might just add that a lot of people get confused about when we're working with somebody or somebody that needs medical detox. That means they haven't drank within so many hours, and it's usually at least 24 hours. We run into cases where IHS has referred them, but when we get there, the facility will not detox them because they're still drunk. So we can't take them then. Also too, we put ourselves at risk because if we're not that familiar with this individual and the clinic has just referred them and said, can you transport them? And then, we'll transport them, but as long as they're not drunk. We run into that several times. And medical detox, like I said, means after they're suffering to get over that, just like people on coming off of drugs. Then they will be admitted. So then we'll lose them, and there's nothing we can do. Now, this past week I have worked real hard with an individual, and there's nothing that I can do to make them go. I had to get the police involved, not to try to get them thrown in jail because I was concerned about their safety and the shape that they were in. And we get calls from family members, well, why aren't you trying to help them? They said, but like I said, unless you know the steps that has to be taken just to get them into medical detox too, that becomes a problem on the family side because they don't understand. We don't ever give up on anybody, you know. We try to help any and everybody that comes through the door. Also, like Mike said, if we have an individual that is 23 years old, and I know what it's like to be a mother with troubling kids, they're an adult, so they have to make the initial contact with us. We can't. They can make the call as a concerned parent, but it's that individual that has to come in and do their own paperwork. So.
Any questions, comments?
Can you kind of just touch on what do you guys see as one of the main barriers for people trying to access information? Is it the paperwork part? Is it transportation?
Those are some of the barriers. A lot of people, when they get to feeling better, when you're down and when you're not feeling too well, yeah, you're more receptive, you're willing to go. But you get to feeling better a couple of days later, then it's like, I don't need to go, I'm okay. Run into a lot of that. There's been times when you have somebody up to the vehicle, ready to go, and then they walk off. You can't restrain them. It's on their own volition. Situations like that, but you know, that's just part of it. There's a number of it.
I mean, I just kind of wanted to touch on that because, like, where you could see this type of facilities helping with those type of things.
Yeah.
So it's just, I think even the thought of, okay, well, we're gonna have to go to a facility that's like an hour away from us, you know, an hour drive, so, well.
And
I don't
you have
know.
just the reverse of that too, because it's going to be the same thing. Well, somebody's going to see me going up.
Mhm.
That's one of the biggest stigmas there is.
Yeah.
You know, is that making that initiative mission. Do I need the help? Am I willing to go up? What if somebody sees me? You know, the shame that we're in. You know, people don't want to do that. And that is one of the biggest deterrents. Did that answer enough?
Yeah, I mean, I know, but I just want other people to kind of hear it too, so they know, you know, what, you know, the benefits of having this type of facility, how it can help people, you know.
Yeah, oh yeah.
You know, get into recovery and trying to stay in recovery too.
Yeah, the positives far outweigh the negatives.
And we're supposed to have a meeting and meet with behavioral health and one of their other staff over there that helps us along this process to getting people in to detox, because there's been some, I don't know how this information is getting out there, but it's just called them. We had somebody call and said, we're just told to bring them to your office and you guys can just take them from there. And it's like, no, they've got to do an intake on his phone with 12 and 12, and then again, they decide, like Mike said, I mean, it's by a school, so they can't have certain people at that facility. So, and we don't know that until they do the intake, you know, and then they'll tell us over the phone, yeah, you can go ahead and, you know, bring them over. But like Mike said, it's in a separate building also, the medical detox. They will do that and then release them even if they can't keep them there. So in that time frame, we're asking them to go ahead and fill the packet out of the, you know, where the individual wants to go. So that's being worked on while they're in there, because the person could be in there anywhere from 3 to up to 2 weeks for detox. Just depends on, you know, your physical well-being.
I just have one more thing, it's just to remembering is that, I've had this issue many times, is that if you're calling on behalf of a family member too,
that is a client of the substance abuse program, they can't release me information. So that's a call sometimes I get too, and they're telling me about it relative, well, I don't know who's their clients are, so I can't say anything, then all I can give is a message back to the substance abuse program, but it's the individual has to release and say, yes, it's okay to talk to so-and-so, but a lot of times they don't. And so when family members call in and they want answers, we're unable to provide that information to them too, unless they want that. So I definitely want to make sure we have that confidentiality and know that we can't provide that type of documentation to them, so.
It's part of our process. When you walk in the door, you choose to use our services, you will do an intake and you will do a release. Anybody else calls for they're not ready?
And Fahmy, to answer your question earlier, SDC down the road, a long time ago, they used to be state certified, and it didn't hinder any of the cultural activities that they did within. So if we choose to go state certified, it won't, yeah.
So since we're closing out our grant, we have worked on our sustainability strategic plans. And so we have seen some gaps that we're unable to fill, definitely with the treatment facility, but we know that they're there. So we will be focusing on strengthening our partnership and our relationship with Indian Health Service with the referral process, trying to make that more efficient process for patients. There is a lot of prevention work that's still going to be done through the substance abuse program and the tribal opioid response. So we'll be really heavy on the prevention and education side. And our third one was we did want to network with universities, medical schools, so we can start looking at those healthcare providers so they can come and work with us too. So sorry, I had one more.
The community.
Oh, we definitely wanted to have the community,
The community meeting up for the tour grant.
Oh, okay, well, I'll get that one too. Our last one is that we definitely wanted to start networking and having we don't have a tribal opioid task force. That's something that we don't have. And so that's something to look at too, to strengthen our reaction time for that. And that would include, we're looking at like law enforcement, our programs here, possibly Indian Health Service, county, city, so that we can better respond to if we have anything. So we are going to work towards that. So strengthen what we can do with our prevention and our outpatient, and then we'll continue to definitely look for monies for our treatment center. So that's some things that we can continue to work on. And then there is a town hall meeting for the tribal opioid program. It's Monday, September 30th.
I forgot the flyer, but it's on the,
I want to say it's at 5 o'clock.
yeah,
Brian, I know
it
you're
will
one of
be
the
in the
speakers.
paper, and then it went on the website,
Is it at 5 o'clock?
5:30.
It's at 5:30 at the Rome Chief Building. So they will have a panel discussion. September is Recovery Month, and so they will be having a panel discussion, and those will be from speakers from Southern Plains Indian Health Board. Brian's one of the speakers. So if you have opportunity, food, maybe some door prizes, but definitely just give some more information out there. So we'll continue to try to have these town hall meetings and community meetings just to keep people updated about our events that we're doing, the services that we're providing, and still pushing the education out there. So thank you all for coming.